Okay, thank you everybody for joining us today. Nezzy's here from our practice at Lewis Center. She's going to teach us about depression monitoring. So thank you, Nezzy, for joining us.
All right, thanks for having me. So as you all know, I'm Nezzy Tashal. I'm here today to talk about a very uplifting topic, but hopefully by the end of the talk, you guys will have a newfound passion for treating depression in your patients. How's that? So I have no disclosures. Today I'm hoping to talk about the prevalence and impact of depression, and I'm going to belabor this point a little bit because I think it is really important to understand how invasive depression is in our patients with chronic comorbidities. I'm going to review screening guidelines, monitoring guidelines, treatment guidelines, and then hopefully introduce you to a relatively newer modality, at least at OSU, for treating depression, which is an online tool to deliver cognitive behavioral therapy to patients called Beating the Blues. So as I have been in my practice this past year thinking about the patients that I take care of that maybe are the most difficult patients in my practice, I've started to think about what are the ways I can interact with these patients, the patients who show up on your schedule, maybe the patients you see pretty frequently, that you see them, they have multiple chronic illnesses that are poorly controlled, and you see them, and every visit that you see them is kind of like Groundhog Day, where you go over the same things, and you talk about the same things, and you maybe adjust a couple things, but they come back to see you the next time, and nothing much has changed, right? And so I've been thinking about those patients, and I've been thinking about how we're changing our method of reimbursement, where we're going to value-based payment, and I've really tried to think a lot about what I can do for that group of patients in whom they have very poorly controlled chronic illness and maybe have very high costs of care. And when you think about those kinds of patients and you think about the ongoing trends in treating these patients, there is a movement toward really approaching their mental health and attacking their mental health in a more holistic way. So you guys may have all seen that the ACP published a clinical guideline earlier this year talking about the management of depression and the potential impact of this, as well as the U.S. Preventive Services Task Force put out a new updated recommendation to screen all patients actually for depression in our primary care practices. And so I think the national trend is this way, and I think, as we move to the value-based payment, it behooves us to talk about this a little more. So when we're talking about costly conditions, you think about the most common ones, right? You think about heart disease, you think about cancer, you think about respiratory illness like COPD. But in the top 5 most costly disorders to treat, actually mental health illness plays a huge role in that, and depression is the majority of that cost. And if you look at the trend over the last 20 years, you can see this data from 1996 to 2006, the cost of mental health disorders actually doubled over that decade, and it continues to rise. So let's just think about a patient in our primary care practice that might just be generic Joe Smith. This patient is WC. Ironically, saw him today, and his diabetes is much better today, even though I put him in this, and it's because he's playing Pokemon Go. But anyway, we're not talking about that today. So anyway, 52-year-old male. He has poorly controlled hypertension and diabetes. He reports worsening diabetic control over the past 3 months. He's not checking his sugars because he says it don't matter, it's always high. He says he's taking his medicines regularly, which includes, 2 shots of long-acting insulin, some short-acting insulin, and oral medication. He's not taking metformin because he says he had diarrhea with it. His blood pressure's up, so it's 158/100 today, and when he measures it at home, he says it's about in that range. And he's done a point-of-care A1C, and today it's 11.9, and last time it was 10.7. So probably all of you can think of a patient that maybe fits the bill in your practice that sounds like that. So you go in the room and just think for a moment, what approach are you going to take to this patient? And I see some care coordinators in the room, so even for you guys when you're on the phone with the patient, what are you thinking about? What are you asking them about? What is going to be your approach to this patient? How are you going to do something different today to hopefully enact a different outcome the next time? So I'll just give you a second to think about that.
Did Mr. Show get read on?
So you might tell yourself a lot of different things, and probably the answer is multifold, right? I mean, there's probably a lot of reasons why this patient's diseases are not controlled. Perhaps he doesn't take his medicines as often as he says he does, and maybe he doesn't because of the cost of the meds, or maybe he doesn't think they work, or maybe he experiences side effects, or maybe he just forgets. Maybe his diet's out of control, so he doesn't choose the right foods, or he has finances that limit his ability to buy the right foods. Or maybe sometimes his sugar's really well controlled, but then he gets the COPD exacerbation, and you give him prednisone, and now his sugar's out of whack again, and he loses, he gets disheartened, and he says, I can't treat my diabetes because even when I get it under control, it goes out of control again. So maybe there are all these things going on, and perhaps there are multiple ones of these things going on. But I wonder how many of you thought about a mood disorder. And that's what I'm hoping to get people to focus on and think about today, in addition to all these other things that are good reasons why people's chronic conditions are poorly controlled. So maybe there's a mood disorder. And, okay. So I think all of us think about mood disorders as an effect of people's chronic illness. So we know when they have multiple chronic medical illnesses that's depressing. They probably, as a result of multiple hospitalizations or multiple medications or psychosocial conditions, we think of them as depressed. But what I'm hoping to do today is to shift the focus to thinking of depression as maybe a cause of why their chronic diseases are uncontrolled, and proactively approaching that depression as one of our methods of treating their chronic illness. So if you look at statistics, up to 8% of all U.S. residents suffer from depression. It results in about 8 million visits annually, and half of those come to primary care. In patients who have diabetes and hypertension, the estimates are as high as 85%. So up to 85% of patients with depression patients with diabetes, suffer with depression. And the usual estimates, when you're just talking about a normal population of patients with diabetes and hypertension, probably closer to 50%. But I would argue maybe some of our patient populations, like here at Morehouse and at East, might be as high as 85%. Depression is associated with a 50 to 100% increase in the use and cost of healthcare services. So again, when we're looking at value-based payment and looking at patients who are utilizing the system, having poor outcomes, this is a group that we want to attack. And if you have patients who have comorbid depression with their chronic medical conditions, it increases the risk for death from all the diseases that are at the heart and soul of an internal medicine practice: heart disease, respiratory disorders, and stroke. If you look at the top 10 causes of illness, you can say, okay, well, mental health is definitely in here because suicide's in the top 10 causes of death. But then if you look at those comorbid conditions I was talking about and look at the fact that depression complicates the treatment of those conditions, you can see that depression is involved in many of the top 10 causes of death. There was a recent meta-analysis done that looked at patients with diabetes and depression, and it looked at 27 studies, aggregate data, and it showed that patients with diabetes and depression have lower levels of self-care. They don't exercise as much, and they're not as adherent to medications compared to non-depressed patients. And as a result, they have a significant association with high sugars, complications of diabetes, and when they have those complications of diabetes, the severity of those complications is also worse. And then, as I mentioned, there's a modest association with all-cause mortality, and particularly mortality resulting from cardiovascular disease. So this slide shows the results of a 7-year prospective study that was done on a group of about 2,500 Medicare patients. And the study was done for the purpose of looking at the utility of preventive care services in patients with Medicare. But this is a subgroup analysis done. And the CESD score here is a standardized tool used for depression that is on you can score up to a total of 60. So the one that we use, the depression screening tool that we use, is the PHQ-9. Your max score there is 27. So you can think of like a PHQ-9 score of 14 being equivalent to the CESD of 26. So the patients with severe depression, by whichever tool you want to show, you can see that if you look at their survival over time, they have significantly lower survival rates over time as the severity of their depression increases. There have been studies that have looked at other comorbidities like depression and diabetes with risk for other conditions. And so there was a study in 2010 that looked at risk of development of dementia. And so we've been here. So patients who have diabetes and hyperlipidemia but also have depression have a much higher incidence of dementia as well. And so hopefully I've shown you enough data to prove that obviously having having depression is a very bad thing when you have other comorbidities. But the question remains then, if you have depression and you treat it, do you then reverse that risk that came from having, you had increased risk because you had depression and these comorbidities, but if you now treat the depression, do you improve that risk? And this is a recent study that was published in the Journal of General Internal Medicine in the spring of this year. And it basically looked at 4 groups of patients who were depressed and not depressed, patients who got usual care and intensive care. And intensive care was defined as patients who were followed over 2 years prospectively with a depression case manager. And that depression case manager actually helped proactively follow patients with depression, escalate their therapy in a stepwise fashion so that if they were seen and their depression was uncontrolled, they would take it to the next level. So maybe they started with citalopram, and if the citalopram didn't work, they increased the dose of the citalopram, or they added cognitive behavioral therapy. And what the graph here shows, the gray dotted line where the slope's going up, is the hazard ratio for mortality over time with increased comorbidity. So the more comorbidities you have, you have a higher risk of mortality if your depression is untreated. So there's the gray dotted line, usual care for depression. So this is what we do in our practice every single day. We do our usual care for depression, and patients who are depressed with multiple comorbidities have a much higher incidence of dying, of mortality, because they get the usual care. In the group who had intensive care, and it's really hard to see, but the gray dotted, or the gray solid line, that's below the 2 black lines, is the group who had depression but intensive care. And what they were able to demonstrate is by doing this intensive care for people's depression, they actually reduced their risk for mortality down to the risk that it coexists with just their comorbidities, but not that increased risk from being depressed. Does that make sense? Kind of a mouthful, but. So I hope this slide for everyone shows us the importance of maybe taking an all more proactive approach to treating our patients with depression. All right, so hopefully that's prevalence and impact. Let's move on to screening guidelines. In January of this year, many of you may be aware that the U.S. Preventive Services Task Force published a new guideline regarding screening for depression. They gave it a grade B recommendation. Their recommendation is actually to screen all patients for all adolescents and adults for depression, and they recommend using a standardized tool. So we here use the PHQ-9. There's some others that are validated: hospital anxiety and depression scale, the geriatric depression scale, which you may use, I don't know, in the geriatric clinics now. I know a lot of us are doing the PHQ-9s or PHQ-2s on patients when we do Medicare wellness visits, but I'm not sure, and I'd be interested in our Q&A at the end to talk about how many people are doing just generic screening for depression in their everyday practice. We all remember the definitions of diabetes or of depression, and the classic CIGI-CAP symptoms. But actually, what I'm suggesting is maybe a more narrow scope than the patients recommended in the U.S. Preventive Services Task Force. Rather, thinking about patients with chronic comorbidities and maybe these kinds of symptoms. So patients who, so what I'm suggesting is screening patients for depression who have these kinds of symptoms, greater than 5 medical visits per year, or a lot of dysfunction, either work-related or relationship-related. Maybe they have a lot of somatic complaints like stress or IBS or fatigue or sleep disturbance, or maybe they come in complaining of memory loss or cognitive complaints, or maybe they just come in like the patient that I showed you at the beginning, WC, who just has poorly controlled hypertension, poorly controlled diabetes. These are the patients in whom I think we should be screening for diabetes or for depression regularly. Got diabetes on my tongue here. One last thing around screening, there is recently a Sentinel event published by the Joint National Commission. I think Jay Lawrence and Debbie Gordish are going to a meeting on this, but there may be some national recommendation that all ambulatory patients should be screened for suicide risk. So if you guys see that come through, and I won't belabor this point because we don't have more information, that's a separate Joint National Commission thing, so there's kind of more information on that to come. But there may be a mandate to screen all of our ambulatory patients for suicide risk as well. All right, moving on to monitoring guidelines. So I think that a lot of us do a great job of adding depression to the problem list. We maybe even start medication or suggest therapy, but then the question is what happens from there? Once we've identified the problem, do we treat it appropriately? And in order to treat it appropriately, I would argue that we have to be monitoring it appropriately. And so one thing is, one part of the clinical guideline is to have proactive follow-up contact and to make sure that we're scheduling regular routine visits for the purpose of reviewing people's depression, and that when they come in, we're actually monitoring them with a PHQ-9 tool or an objective tool that allows us to quantify the degree of improvement in their symptoms, obviously along with the patient's report of how they're doing. If you do that, an example of how to monitor whether a patient is treated or not, if you use the PHQ-9 score, for example, a response is defined as a 50% reduction in symptoms. So if a patient comes in and their score is 16 and you reduce their score to 8, that's considered a response. And if you get their score to normal, where they're in full remission, that's a PHQ-9 score of less than 5. Also in the monitoring guidelines, if patients are being seen with behavioral health, it's recommended that primary care physicians and behavioral health providers actually collaborate with one another and talk about the patient. I'm not sure how often that's being done, and there's a lot of, in my opinion, barriers to that, but that is part of the official recommendations of what should be done. And obviously, I see the benefit in that. I just don't know practically what to do. So in terms of PHQ-9, a lot of you asked me about where you can put this in the medical record, or I've talked to you guys a lot about this. I just wanted to briefly review this. There are a couple different places where you can enter PHQ-9s. Under the screenings tab in EPIC, this is kind of 3 screens overlaid over each other. So in the screenings tab in EPIC, if you click screening and then go to depression and click on depression, the next tab over, yep, that'll bring up the tab on the right here. And that is actually a PHQ-9, and you can click through the patient's answers that hopefully they've completed ahead of time in the room for you. You have to hit the word close or it won't save that. And then an alternative way of documenting it is in the, this is a screenshot of what it looks like once you've documented it, and the previously filled value will show in the right-hand column, so you can compare really quickly if you're trying to get that answer to whether it's improved or not. Another better way to do it, I think, is actually under the flow sheets tab, and the reason I think that is this one contains both the PHQ-9 and the GAD-7, which a lot of people do together. So in that white rectangle at the top up here where it says behavioral health screen, a lot of you will not have this tab yet. You'll have to type in the word behavioral health screen, but if you do that, it will forever keep that in your, when you bring up flow sheets, that'll be one of the file folders that shows up at the top here. And then you can get the PHQ-9 and the GAD-7.
I'll add that if you want to find that faster, if you just type in GAD, GAD, and hit enter, it'll get you the same.
Oh, okay.
That's the faster way to do it.
And so you can enter both the PHQ-9 and GAD-7 here. It also will show you the comparison values, but there's a little bit of a glitch in the system for comparison here sometimes. If the computer doesn't perceive that it's a related encounter, you can't see the comparison, but if you go to review flow sheets and bring this up, it will. So I have, many of you have emailed me about this. I have talked to EPIC. I've belabored the point. I have multiple tickets. This is the best it is right now. I'm always hoping for better, but that's as good as it is right now, as far as I'm aware. All right, so that's monitoring. So last thing is treatment guidelines. So the Annals of Internal Medicine this year, American College of Physicians published a clinical guideline around treatment of depression, and it recommended using cognitive behavioral therapy or a second-generation antidepressant as your first-line treatment for depression. There also is no contraindication to doing both at the same time. And it's recommended that folks be followed through 3 phases of treatment, and this might set the rhythm for when you're seeing them back in follow-up. There's the acute phase, the continuation phase, and the maintenance phase. And of course, during all of these phases, you're monitoring them for relapses or recurrence of their symptoms. And so I just was going to review that there was a major study published in a psychiatric journal back in 2010 called the STAR-D study 2006. The STAR-D study that looked at patients with depression and how many sequences of changes or escalations of therapy it took to achieve remission. And actually, after the first step, only about 30% of patients actually achieve remission of their depression symptoms. So if you're thinking about seeing a patient, starting them on a medication and thinking you're done, you might be done about 30% of the time. But to get even 70% of people into remission, it takes about 4 escalations of therapy or changes in therapy to get patients with controlled symptoms. So just kind of a reference point there. I talked about second second-generation antidepressants, here's just a list of some of the examples of that. So SSRIs, SNRIs, like Effexor, venlafaxine, and then there's bupropion, mirtazapine, trazodone. These can be used alone or in conjunction with one another. So, for example, one of your escalations of therapy, if you've started an SSRI, might be to add bupropion or to add trazodone, and these might be to target specific symptoms like trazodone to target sleep or bupropion to target sexual side effects. And then, obviously, we talked about cognitive behavioral therapy, and so that's kind of where I'd like to spend the last bit of my time. A quick note on other treatment modalities. There are no randomized controlled clinical trials that suggest that any of these things actually are superior to the previous. So obviously, second-generation antidepressants, CBT, are the first line. But in patients who are not willing or not able to get those two modalities, there is some evidence that suggests all of the following might be helpful in treating people's depression. So behavior activation is another form of therapy, not cognitive behavioral therapy, but there are trained psychologists who help people come up with game plans to increase their exposure to previous positive life experiences. So, for example, this is for that patient who maybe comes in and tells you that their diabetes was really well controlled when they were living somewhere else because they had this group that they did, this activity that they did, and now that they're here in Ohio and they're indoors all winter, they don't do that anymore. And so if you can find a therapist who specializes in behavior activation, that can be a really helpful modality. Physical activity by itself has been shown to help increase mood, and obviously that would help control their chronic medical conditions as well. And then in the integrative medicine realm, there's acupuncture, which is particularly helpful for patients when they're pregnant, yoga, St. John's wort and SAMe, and the cautions on those two are just interactions with other medications and the fact that those drugs are not FDA regulated when they're produced, so patients may or may not be getting what they think they're getting in a bottle of it. Saffron, and then looking at various vitamins and supplements, so magnesium, zinc, omega-3 fatty acids. Raj, I'm sorry, cannabis, there's insufficient evidence that long-term use of cannabis actually improves mood in the long term. And then there's some evidence for light therapy, particularly in patients who suffer from what they consider seasonal affective disorder. All right, so last little bit of time, I want to talk about online cognitive behavioral therapy. So there is a program that's been used for the last, 15 years in Great Britain and Australia in their national healthcare services, which is online cognitive behavioral therapy. And this is a pre-prescribed program that every person who interacts with the program experiences exactly the same way. So there's no health coach in the computer that's now interacting with patients individually, but rather a pre-programmed platform that patients go to and interact with. And the idea is that patients first watch a group of people from various ethnic backgrounds, various demographics. So they have like a single mother, they have a widow, they have various ethnic backgrounds. These people, and they watch them in their everyday life, and these people basically talk about how they have experienced depression or anxiety in their life. Or they might show them an example of a situation where they have disordered thinking about a pattern of, or a disordered pattern of thinking in a certain situation. And then the program asks the patient to think about their own life and their own self, and do they see themselves in these patients, and do they understand how that could be a disordered way of thinking. And then the program gives them homework to do. Think of 3 examples of this. Think of something different that you can do in the situation for the next week, and then you come back to the program and interact with the program again, much the way you would do with a counselor. And when this program has been looked at in randomized controlled clinical trials, it actually has pretty good efficacy at inducing both remission and response to therapy. They have studied this program in patients who have no other therapy, so have no medications, no cognitive behavioral therapy in person with an in-person counselor, and also in combination with any of those things. And it does seem that scores, PHQ-9 scores improve progressively, and that's maintained at initially when they finish the program, as well as 6 to 12 months after. So this program is currently available to OSU Health Plan patients for free and available through the Department of Psychiatry. We can link people up with this for a $50 fee if they don't have OSU Health Plan. And so I have a link here. I don't know what kind of time we have, but I can show anyone who wants to stay. I can pull a link up of what the program looks like, and we can talk about it. Lewis Center and Morehouse have this program up and running for their providers, and other people who are interested, we're happy to get this going. There's some logistics involved with the billing and such that we have to get set up. But I'm hoping that people will see this as another modality for treating patients who have been very maybe difficult to get into in-person therapy or have side effects with the second-generation antidepressants. Here's just an example of what the sessions look like. So here's some of the cognitive components and the behavioral components. This is just basically the index from the introduction. And I guess I have the video and I can show that at the very end here. So hopefully people have heard from this talk the importance of identifying and really aggressively going after patients who have depression and chronic comorbidities. I hope that we are able to measure this in a more standardized fashion and design our follow-up around monitoring patients with standardized tools, and then using that tool to allow us to guide our therapy and escalate therapy as needed. And lastly, I'm hoping that folks can get interested in utilizing the Beating the Blues in their practice, and I will take any questions.
All right. Well, thanks, Nezzy. I thought that was a wonderful review. I have to get going here pretty soon, but the thing I'd leave the group is I don't know that we can do enough for our patients with depression, and my own personal reflection on it is I find it to be one of the most gratifying illnesses to treat. So when you see people improve and watch them come back with a completely different energy level and engagement level, it's really gratifying. So thanks for sharing these additional tools with us.
Do I need to do anything for?
Jared's going to proctor the last part of the talk here for us.
Are there any additional questions?
So now this is for the CAC clinic. We are using PHQ-9. So based on the literature, we can use the GDS or PHQ-9. I would just want to be consistent with our whole movement here.
Yeah.
So we just use
I think it's all right. So I think so long as we're using a standardized tool and it's being followed over time, the idea is just to say, okay, now I've started something. So we think there's two problems. One is that depression is under-recognized, but the second is that it's probably under-treated. So if you have a tool where you're standardly measuring how people are doing and they're actually not improving on that tool, it gives you a trigger to now escalate their therapy, change their therapy, find some other way to interact with the patient to try and improve their mood disorder. So I don't think it matters if you use one or the other, but I think it should be used over time, the same one over time.
So the course for the drug therapy with the SSRI, SNRI, so we don't have any guidelines for the courses for the therapy, because oftentimes I get some letters from the insurance company that all your patients on this for a long time and stuff or things like that. I don't know whether you guys get the letters from the insurance.
So the main letters that I get from insurance companies are when patients aren't filling their scripts on a regular basis. In terms of length of therapy, there is no guideline, and actually the recommendation is that patients should be maintained, if they have a response, they should be maintained for at least 3 to 4 months on that therapy. And then at that point in time, it's an individual discussion for each patient about whether they should have continuation of that therapy or a trial off medication. But that's also a place where we falter sometimes, so patients will get better for a while, they stop taking the med, and then we stop monitoring to see if they've had that relapse or recurrence of their own. So. Other questions?
Yeah, this is Jody. I was going to say that I have a patient that works in the psychology department, and she works closely with the James. They're doing a trial with the Beating the Blues program. And I think that the enrollment criteria is for any patient who's ever had cancer. I think they get some kind of free enrollment for Beating the Blues. So,
oh, wow.
Yeah, I can dig up her email, and we can send it out to everybody. But just so you know, for people who maybe can't or don't want to pay for it, that might be another resource for your patients who either have active cancer or who have had cancer in the past.
That's awesome. Gail and I actually approved for one, applied for one of the patient safety grants to try and get that $50 fee waived for people so that we could just, go at this, and it didn't get approved. But if patients with cancer, that'd be a huge group. That would be great. All right, go ahead.
I was going to just say, what I see very frequently is, you'll have people, you'll treat them, they'll have a PHQ-9, it'll go from 15 to 11 or 12, and they'll come in and say, I'm feeling so much better at that point. And they're kind of a little bit hesitant to start new medications or add on. What's sort of your thought in those cases? Do you really push them to do more, or if they come in and they tell you that they're feeling pretty well, do you worry about the score as much? And I guess some of that is just with the correlation between the scores and always how people are feeling.
I think that the important thing is whether they're severe or not severe. So if they're severe and they can remain in the severe range, that'd probably be somebody I'd stay really vigilant with. If they're severe down to moderate, but they're telling you they're so much better, I think the sensitivity of the tool is less, and I would probably just follow the patient. So yes, officially the guideline is a PHQ-9 score that's cut in half, but I personally wouldn't escalate there based on the score. I don't know if other people have thoughts on that. I don't think the guideline officially says anything, but that's probably my thought.
Are there any other questions? All right, Nezzy, thank you very much.
Thank you. Everybody hangs up. So,
I'm just this morning about how we